Welcome, everyone, whether you are in the early morning or afternoon time. Welcome to our quarterly webinar series here at the AIM Center. Our webinar topic for today is treating substance use in collaborative care. So we welcome you to our webinar series for today. Next slide. I am Monica Williams Harrison, a clinical trainer and practice coach here at the AIM Center. I am also sharing the spotlight today with some of my colleagues from the AIM Center, Sarah Barker, Associate Director, and Christy Malmstrom, our Program Operations Specialist. Next slide. So here at the AIM Center, our purpose is, of course, to inspire providers, researchers, decision makers, all of those who are working in healthcare setting. Our goal is to transform and improve patient outcomes, and we do this through researching evidence-based approaches to behavioral health integration. Next slide. Some Zoom housekeeping. I know many of you know what they are if you've joined us before, but just to highlight that this webinar is being recorded. We will send out a link at the end that has the slides as well as this recording attached to it. We'll send that to you if you registered. Please make sure to use the Q&A function that should be at the very bottom of your screen for any questions that you might have for our panelists. So we will have a Q&A section at the end of the presentation today. So not the chat box. So all of your questions, please put those in the Q&A section because that's where we'll go to pull questions for our panelists. Any general questions that you might have that are not about treating substance use in collaborative care, we ask that you bring those questions to one of our office hours, which Christy could drop that information in the chat box for those who are not aware. We do have monthly office hours, one that's on implementation of collaborative care and one that is on financing of collaborative care. So if you have questions related to that, please bring those to our office hours. Today, we want to give our panelists the opportunity to answer questions that are in their subject matter expert realm for today, which is treating substance use in collaborative care. Next slide. So our learning objectives for today are to identify evidence-based substance use screening tools for primary care, lists research that demonstrates the evidence base for treating substance use disorders in collaborative care, describe some important considerations for those of you who are providing care to individuals that have a substance use diagnosis and utilizing collaborative care, and then of course to describe the collaborative care team skills needed to be able to provide that type of service to patients in primary care. Next slide. So just to level set, before I kind of turn things over to our presenters for today, we always level set with the principles of collaborative care. So there are 5 principles of collaborative care: patient-centered care, population-based, measurement-based treatment to target, evidence-based treatments, and accountable. You'll hear those things, some of those things mentioned throughout the presentation today. So all is in line in terms of utilizing collaborative care in your primary care setting as you're treating patients with substance use. Next slide. So our esteemed presenters for today, I will introduce them briefly. So we have Mark Duncan, who is a director of the Psychiatry and Addictions Case Conferences. We have Elizabeth Austin, who's a senior research scientist. And we have Paul Berry, who is a clinical trainer and practice coach at the AIM Center. You will notice that all of our presenters from today are with the University of Washington. We're all different roles because we're a big university, but we are at the University of Washington and sharing the floor with them for today. So I will turn it over, next slide, to our first presenter, which is Mark Duncan.
All right, thanks, Monica. And great to be here this morning or this afternoon, wherever you may be, for filling out some of my background. So I've been psychiatric consultant in a collaborative care program here at the University of Washington for almost the past going on year 9, or actually going on year 10 right now. And then my other background is as an addiction psychiatrist with kind of a special interest in bringing substance use treatment to primary care settings, and have been just doing a lot of that work over the years within different models, and have done a lot of work with providers here at the university, but just around the country on these topics. And so this is a special interest to me, and I appreciate the chance to talk through some of the research here at the beginning. Next slide. So if you look at what are some successful models of integrating primary substance use disorder treatment into primary care, 2 themes kind of emerge. One is a team-based approach, and then the other is on-site psychosocial support. Now, these themes are actually highlighted in a primary care scoping review from 2017, but when in my experience, this is broadly applicable to other substances as well, specifically something like alcohol use disorder. And it's not a big surprise when we do when in this scoping review, one of the things that they really highlight that the team-based approach does is, one, at the very minimum, it definitely dramatically increases the capacity for your clinic to treat patients with a substance use disorder. Whereas in other sorts of like models where maybe an isolated clinician here or there, or someone who kind of opens up a kind of a specialty clinic, their capacity for treating and opening up to a larger population is limited. But team-based approaches, as we all have experienced with collaborative care, expands that reach and allows a greater number of people to be helped. The other piece is this on-site psychosocial support. A paper from several years ago now looked at what were several barriers to primary care clinics to providing treatment for opioid use disorder. And one of those highlighted was the lack of psychosocial support. We all know that mental health disorders are very common in patients with substance use disorders, and additional support is going to be needed on that front. But certainly also additional support is going to be needed just as people start their recovery process and start doing things differently in their lives and learning how to cope with things beyond what they were doing with substance use. So those are 2 themes that I think are should be pretty familiar to anyone doing collaborative care, and it was something I wanted to highlight. Let's move on to the next slide. What are some other reasons for collaborative care as thinking about leveraging it for substance use? Well, it is obviously the most well-studied and effective evidence-based model for integrating mental health disorders into primary care settings. It is widely disseminated, so you have kind of an existing backbone for incorporating this strategy already in clinics. It's going to address key barriers for additional support, such as psychosocial support or co-occurring mental health disorder treatment. The principles lend themselves to the treatment of chronic relapse conditions. As we know, the collaborative care is coming out of this chronic care model, as Monica, those principles is highlighted earlier by Monica. And financial support is there. So the question around sustainability, a lot of models for integrated care can be effective, but how do you keep these afloat? How do you pay for the staff? Collaborative care has that built in at this point at most sites across the country. The other thing we know is that mental health disorders are commonly found, as I mentioned, in a study from data from 2015 to 2017, a national survey on drug use and health conducted by SAMHSA. 64% of patients with OUD had a mental illness in the past year. Again, if you are working in this sphere, it is uncommon to find those who do not have a co-occurring use disorder. And untreated co-occurring use or untreated mental health disorders are going to have an impact on their SUD treatment. Similarly, untreated SUDs are going to have an impact on on their OUD or SUD treatment, on their mental health treatment. And so by really trying to address both of these in some sort of integrated way, you're going to have the best response, and collaborative care is well positioned to do that. Now, these are not new reasons. Many of us probably knew this, and this is certainly the case in some of these studies I'm going to highlight here. So let's go to the next slide. The first study I'm going to highlight is the Summit trial. This trial has been around now for a number of years. The initial findings were published in 2017. And the Summit trial looked specifically at using the collaborative care model for opioid and alcohol use disorders. This was not an intervention that was addressing both mental health issues and substance use, really just opioid and alcohol use disorders. They identified patients using some brief screeners that the MAs would hand out and then kind of review, and that was what led to people being referred to the study. Once they were referred to the study, they were then separated into two groups, which were then compared. One was the collaborative care group, as you can see there in the green column, and then the other was the usual care group. Now, what were some of the elements? Now, this was at an FQHC. They had done a pretty extensive amount of preparation to start this trial in the months and year leading up to this. And you can see some of the demographics here. 49% of the participants were unhoused. Now, what were some of the elements that were involved in this intervention? You had the care managers, as is typically the case, but you also had therapists. So there was two separate groups that were a part of this collaborative care team. You had waivered clinicians when the waiver was required to prescribe buprenorphine. They had weekly caseload reviews, as is common in collaborative care setups. There was the registry, and there was a measurement-based care tool. That tool itself was developed by the research team and had not been used previously. So there was lots of similar components with some additions to it as well. And then a couple of other points on this. The team meetings were involved the care manager, care coordinator, and the therapist, and were led by clinical psychologists, which is a little bit different than, say, most collaborative care programs where the consulting psychiatrist is really going to be in there. And I think that has some effects on the outcomes, which I'll highlight in a minute. And then the outcomes that they looked at what was the amount of any evidence-based treatments, specifically therapy or medications, that were delivered to the intervention group versus the usual care group. And then they looked at self-reported 30-day abstinence. You can see some of the contact intensity there. The goal was 6 sessions for the therapy. The goal was the use of either extended release naltrexone, also known as Vivitrol, or buprenorphine naloxone as the two main meds that they were looking at to see how often were those given as part of their outcomes. So let's go to the next slide. All right, so what did they find? Well, admittedly, it's a little bit hard to compare because usual care, there are some unknowns as far as the level of follow-up, but from the data that they could collect, they found that engagement was pretty good for collaborative care. 93% met with a care coordinator who were part of that initial cohort at least one time. 45% had at least one therapy appointment. 22% had at least 2 therapy appointments. So there was some follow-up there based on those screeners, which honestly, that step from the screener to the follow-up is always a challenging step to make for mental health disorders, but certainly for substance use disorders. And so, getting to that 93% of one-time contact, honestly, I think is pretty good. Now, what about some of the delivery of evidence-based treatments? So if you are familiar with this study, you know that more people in the treatment group who were involved in collaborative care had more therapy sessions, 36% versus 11%. But the delivery of medications, so that was the use of buprenorphine naloxone for OUD or extended release naltrexone for AUD, was the same between collaborative care and usual care, which is kind of interesting. And in the context of OUD, pretty dramatic because medications for OUD is arguably foundational for the treatment of OUD, and really the first thing you're going to be talking about in trying to get a person on versus therapy. Now, there's a couple of reasons for that I think is part of it. One of which was a bit of their protocol, where they really reserved meds for the use in more severe use disorders, as they had been defining them, versus kind of moderate. And really more the standard of care is offering medications for people with moderate severity problems and beyond in most cases these days. The other thing is the lack of the site consultant in those care meetings. Being a site consultant for the last 9 years now, a significant part of our discussions in those caseload reviews is around medications, whether or not they should be used or not. And then, but it is part of the discussion for most patients, which may not always be there if you're not in that prescriber role. Okay. So, I think it shows definitely some promise. Now, what's interesting is that 30-day abstinence, it was beneficial even with the lack of improvement on the use of medications. So to me, I think it kind of points to some of the strength of this team-based collaborative care approach. Next slide. All right, so here is a more recent study where they basically took an existing collaborative care program and then added on OUD treatment. This is out of Dartmouth. And this is, I think, a pretty realistic sort of scenario that a lot of our clinics might be in, where maybe you have some primary care providers already doing OUD treatment, and you're looking for ways to kind of leverage some of your existing team-based care to bring to that OUD, because for all the reasons that I had highlighted earlier. And one of the goals they really were trying to do was simplifying the treatment of co-occurring disorders. Again, we know that co-occurring mental health disorders is pretty common in patients with OUD. And so is there a way to kind of bring that integrated care in a much more convenient and accessible way for people? The team itself consisted of the behavioral health clinician with the site consultant, the PCP, so very typical collaborative care team that most sites are going to have. Now, how did they identify patients? They ended up using an electronic screener, which Elizabeth will be talking about the use of screeners here. But this is what they used to help identify people. And then once they did identify people with the use of MAs, they were then referred into this to the behavioral health consultant or behavioral health clinician, who then would kind of do some triaging there to figure out if they were going to be a good fit. How did they get the clinic ready? So they did several educational sessions for all the staff, not just the providers that are doing the referrals, but anyone who's going to have some contact with the patients, which I think is a notable and idea that I want to highlight and star, because when you are treating any sort of substance use disorder, people with those issues are going to pick up on things all along the treatment trajectory. So it is important that all of the staff knows kind of the approach to take, and just to kind of make patients with substance use feel welcome and supported while they're at the clinic. They did several 1-hour clinician trainings. They did some waiver trainings when that was needed. They developed workflows and talked through, what was the task sharing between the PCPs and the BHCs and so forth. And about the clinical service. So what did they actually include? So they added on some brief counseling that the behavioral health clinicians that we're going to provide, that is including some referral to mutual help groups, some care coordination there to help people kind of get plugged in with some more specialty therapy options. They would meet with people weekly to Q4 weeks, so very similar to how you can normally approach a normal kind of interval sort of situation with patients. And then the medications for OUD was just mixed into the normal PCP schedule and practice. Again, very similar to how a PCP might manage depression, antidepressants or anti-anxiety meds, but with the additions of the urine collection, reviewing PMP, and the completion of the BAM with the brief addiction monitor, which was used as their measurement-based tool. And then they had some weekly team meetings to support this, development organization-wide guidelines, e-consult with specialists, and so forth. So they really try to shore things up at the beginning and provide ongoing support for this. Next slide. So what did they find? All right, so they saw that their number of waiver providers increased from 11 to 35 after the intervention, who was writing at least one prescription. And it is important to note that you want to track people who are actually prescribing buprenorphine. The number of PCPs treating 5 or more patients increased. I think this is a notable thing. Again, team-based care can increase capacity. And so this is what we saw with this intervention, which I think is a very positive outcome. The number of new buprenorphine patients increased also. So again, that peak, that capacity is important. As people start to know you are treating buprenorphine and you're a safe place and a supportive place to do this, more people will come, which is the idea. As the opioid epidemic continues to roll on, and we saw that this was, again, increasing capacity. Now, how are they doing as increasing retention? We saw it at 53%. Now, for context, in general, kind of a national sample of primary care clinics, that's gonna hover closer to around 30%. So they saw a significant improvement in retention, which is arguably one of the key metrics to watch around OUD treatment, because it's associated with lots of other good outcomes, such as reduced drug use, increased mortality, or reduced mortality, increased quality of life, and so forth. And then people were using less opioids during this time. Now, here's some survey responses. They looked at 60, they did an all-staff survey, 63 providers responded. 16 of those who responded had a waiver, 47% said they did not have a waiver. The 16 who participated felt this was a positive experience, appreciated the ability. 47% who had no waiver. Of those, 58% said they were not interested. They were concerned about additional time demands, lack of interest, belief this was outside their scope, and so forth. This has been changing quite a bit from like 10 years ago, but it is still an issue that you are going to face as you start to try to do this sort of work. And let's go to the next slide real quick. So in summary, collaborative care can be an effective way to support and deliver SUD treatment, increasing capacity. You see some improved outcomes, delivery of evidence-based treatment. But you are going to need to do some groundwork on building up that workforce. One, around education, helping to address stigma that is still there in clinics, and then the need for ongoing support. And so I think the research takeaways that I have are promising, but you do need to kind of, again, just be aware that you are going to probably meet some resistance with some providers, which can very much derail any sort of collaborative care program if you get a lot of pushback and people are not interested in using it and so forth. And so anyway, I think there's some promise here, and I am going to turn things over to Elizabeth here to talk about some of their findings on screening, and that's a review of the evidence.
Great. So welcome, everyone. My name is Elizabeth Austin. I am a research scientist at the University of Washington, and I have been working in the implementation and evaluation of evidence-based practices for mental health and substance use for over a decade, in particular, the use of patient-reported outcome measures like the PHQ-9. In this next segment, we are going to talk about integrating routine screening for substance use into practice. Next slide. We wanted to spend some time talking about this because integrating screening can be a pretty big practice-wide change, but also being able to systematically identify patients in need of SUD care is an essential component of your collaborative care workflow. So the work to implement screening can really lay the foundation for much of your collaborative care practice overall for this population. Regular screening for substance use in primary care is a recommended practice. The U.S. Preventative Services Task Force recommends specifically routine population-based screening for drug use in primary care settings. But we also know that on the ground, these practices are quite variable. They're influenced by many factors at many levels. And there is some pretty limited guidance on for health systems on how to do this type of screening well. Next slide. So whether you are just starting to think about your SUD screening implementation or further along in your planning stages, there are some key steps that we find helpful to anchor your work or kind of your thought process around the work. The first is we recommend taking stock of what you already do, and you might be surprised. We see this a lot in implementation of patient-reported data. that by the time teams launch an implementation effort, they often are already implementing quite a lot that kind of evolved organically. They just haven't had the opportunity to have that bird's eye view of what's happening in their practice. I encourage you to look at, for example, your Medicare annual wellness visit tools, your new patient intake tools. Asking about substance use is probably already part of your practice. And that can be important not only to help make sure that as you improve upon those workflows, that you're not creating duplicate workflows, but this is also an important framing for the clinic, that we're not doing something new, we're just improving upon existing practices that are already routine parts of our care. We recommend getting feedback from all stakeholders, recognizing that screening processes and, as Mark highlighted, SUD care processes impact everyone in the clinic, not just the primary care providers who might be prescribing medications, but truly every clinical and administrative role is probably going to be involved in supporting these workflows on the ground. Next, we recommend thoughtfully selecting SUD measures, and there are many considerations in that measure selection process. You can, for example, use a more general substance use measure, or you can opt to use specific measures for alcohol use versus opioid use or cannabis use. There are measures that are brief and simple, but maybe offer less information to support clinical decision-making, and then other measures that might be a little bit more longer and complex to administer, but could support clinical assessments in more productive ways. Providers will certainly have preferences of which measures are going to help them in their clinical assessments and ongoing management. The capabilities of your electronic health record or other health information technology tools will probably be an influencing factor in your decision. But importantly, when thinking about screening, you also need to consider how these measures will eventually feed into your collaborative care workflows, especially by supporting measurement-based care. So having these considerations in mind and really looking at which measure is going to best support your clinic's goals for collaborative care will be an important part of your implementation process. And then lastly, once you know what measures you want to use and you have feedback about what's important to your stakeholders, we encourage you to design workflows with the end in mind. And what we mean by that is not just focusing on getting the screener done, but really focusing on the goal of connecting patients to needed care and seeing improvements in their outcomes and building your workflows through that goal, not just to the point of having data collected. Next slide. I wanted to take a minute to talk about what it means to screen. And so in some prior work by my team with some systems engineering colleagues, we looked at screening workflows across dozens of clinics, and our goal was to identify the common elements that could be replicated from clinic to clinic and could help us really understand workflow across all the variation that we see. And so from that work, we identified these 5 core steps that we saw in every screening implementation. You can think of this as a blueprint. Regardless of kind of the local setting, you will have steps related to deploying the screening measures, to figuring out how it's assigned and sent to the patient. You will have steps to collect the measure, helping patients know they have a measure to complete and helping them complete it. You will have steps to track whether the screener was done and how you alert the next care team member that a screener is available and needs review. You will have steps around reviewing that measure, ideally in that clinical visit with the patient and provider together. And then lastly, you will have steps to document the result of that screener and the discussion around it in ways that can support the appropriate follow-up care the next time the patient is seen. Next slide. But as we know from the literature and our own implementation experiences, there are some unique barriers for SUD screening specifically. We see in the deploy step that for SUD screening, it's more often targeted as opposed to that population-based approach or that systematic approach to delivery of screening tools. In the collect step, we see things like leading questions. So the clinical staff person hands the patient the alcohol screener saying something like, "You don't drink, right?" And other ways that might bias how a patient feels comfortable responding to a measure. In terms of the track step, we often see that the documentation of screener completion and alerts are not integrated with other common screening tools, for example, the workflow for vital signs and the visit for the patient that day, leading teams to look elsewhere and often miss a screening result when it's available. In terms of the review step, we hear about providers having limited confidence for talking about substance use, responding to a positive screen, and making a diagnosis. And then within the document step, we continue to hear fear of placing either an SUD diagnosis or the result of a positive screen or a discussion around substance use in the medical records. So as you can imagine, these barriers quickly reduce the quality of SUD screening practices over time. Next slide. I wanted to share a recent implementation experience from this team where we helped 10 clinics implement routine screening for opioid use disorder. And in that, we encountered many of the barriers I just described, but we also identified some helpful strategies to address them. And so I wanted to share those. There is some descriptive information about the clinics here, but mostly what I want to highlight are these last 3 rows, which show that clinics had a lot of flexibility to tailor their workflows to their local setting. And as a result, the clinics that we worked with, they took different approaches to how often they asked the screener, the types of visits that they used or incorporated the screener into, and different modalities, paper versus electronic, for capturing the screening information. So these were very real world experiences of clinics kind of in the trenches of advancing their practice to incorporate OUD screening. Next slide. First, we'll share some of the barriers and strategies related to their workflow design. And so the first major barrier that we met was that clinics found that deciding who and when to screen was a lot more complicated than they anticipated. While it was easy to say, we'll ask patients once a year, as many of you probably know, there are many types of annual visits. There are patients that come in annually but don't come in for annual visits. And so really defining the logic for when patients were due for a screener led to a lot of frustration and incomplete workflows. And so the strategy that clinics found most helpful for this was to move to a more universal approach of screening every patient every visit. And we did have clinics that started with that annual approach that moved to the every patient every visit approach because it ultimately reduced burden on staff. Even though the screener was being asked more frequently, there was less thought involved in determining whether a patient was due or not. And so it was an easier lift for staff all around to ask it more frequently. Next. Another workflow barrier that we met was in ensuring that those that did have a positive screen received the appropriate follow-up. And this goes back to a few slides before where we talked about thinking about the end goal, not just being collecting the screening information, but really having that workflow go all the way through the process of alerting the care provider, ensuring that they're able to provide the correct follow-up and supporting patients in their next steps in care. Some of the strategies that were particularly helpful for supporting the follow-up for positive screens were using audit and feedback. So giving providers a list every week, for example, of the patients of theirs that had been screened and had been screened positively to ensure that they had caught that and were able to provide the right type of follow-up as soon as possible. And then the use of either flags within the electronic medical records or other visual cues, such as placing the screener on a different color of paper to really ensure that it was very visible to care teams in the moment of the visit, and it was less likely to be lost. Next slide. In terms of training and the people involved in administering the screener, one of the barriers we met were that staff were often uncomfortable or had some uncertainty delivering the OUD screener. And this quote you can see on the right, I think really perfectly encapsulates that, saying that as a newly waivered PCP, it's tough to feel empowered and educated to say to a patient, well, I think you have a problem. And so we heard certainly that from primary care providers, feeling uncomfortable with a positive screener in front of them of how to start the conversation with the patient. We also heard it from nursing staff who felt uncomfortable answering the questions that patients asked of them to clarify questions they might have about the screening tool and what it was asking, and even of front desk staff or other administrative roles who felt unsure about why they were asking the screener of patients and what services their clinic even offered, or what care might look like. So some of the strategies that we used to help mitigate staff discomfort and uncertainty included providing staff with scripts, which gave them the language of how to talk to patients, offering repeated trainings and one-on-one coaching, either with local clinical champions or external mentors. And then some clinics found it helpful to facilitate forums such as staff meetings where they were able to talk about screening, hear staff concerns, and work through those as a team. And that was helpful for sorting through some of the negative emotions that staff might have felt. Next. Another barrier that we met in terms of the people involved was some discouragement. So as clinics worked to implement this new practice, as we all know, it's a big lift to change practice in any way, and implementing a screener is no exception. They felt discouraged when they weren't identifying patients who were eligible for services every day or every week or even every month. And certainly for OUD, we know that the prevalence can be quite low, but that told us that we needed to do a better job of setting expectations up front about what we anticipate finding, what it might look like, and what success would be in the use of these tools. And in primary care settings where we are continuously asking more of primary care teams, this is a really important strategy to utilize as early as possible, is to really make sure the expectations are clear about what we think the yield will be. And to remind care teams that the goal is to connect patients to care. And even if we may not find patients often, even connecting one patient can be a life-saving opportunity for them. So really framing the goal around those kind of larger outputs as opposed to high yield. Next slide. The last area where we met some barriers related to stigma and community engagement. And so as our clinics launched their screening efforts, they found that patients were still not necessarily thinking about primary care as the place where they could receive care for opioid use disorder. There's certainly going to be variation region to region and how this looks. But this led clinics to think about what the opportunities might be to do some more advertising. As this quote also highlights, their screening might have worked out differently if patients knew that as part of their services, they were actually offering buprenorphine and other types of treatments for OUD. But without that clear understanding, patients may be less motivated to either disclose use or talk about the care needs that they have. So advertising was an important strategy that most clinics encountered and tried to implement. But in that, thinking about how their services aligned or complemented the other services in their community. We had clinics recognize that there was maybe easy access to methadone in some places, but they could offer easier access to buprenorphine. There were places that had waiting lists that maybe they could offer quicker access. So just making sure that you're familiar with what's available in your community and are framing your services in a way that complements it for patients. Next. Finally, and this echoes what Mark shared in his slides as well, we did see stigma, both in terms of the stigma that patients may carry from their sort of community interactions, the stigma that staff may still be carrying in terms of their perceptions of patients with, in this case, opioid use disorder. And so that stigma did continue to deter patients from disclosing on the screener what might be their current use or need for symptoms. We heard clinics talk about patients feeling uncomfortable being honest, being afraid of being fired from care, even if that wasn't a policy of this clinic. It may be policies of other clinics within the same healthcare system that patients are seeking services in. And so that's important for clinics to keep in mind, that patients are not only seeking care within their setting. Some of the strategies that were helpful for this included anti-stigma training for staff, but also taking a look at the policies throughout the clinic, not just specific to substance use care, but really looking at all policies around, for example, missed appointments, early refills, pain contracts, controlled substances. All of those may have been developed in a different time. And now that the clinic is thinking about, now we want patients with substance use to come here and offer them services. I'm thinking about ways to reduce stigma in those policies that may not be as apparent. but will still continue to deter patients from feeling safe answering the screening questions and talking about their needs within clinical appointments. So in summary, implementing routine screening for substance use can enhance your ability to connect patients to needed services and is an essential component of your collaborative care practice if you're expanding collaborative care to substance use disorders. But thoughtful attention is needed to ensure your workflows are robust, your teams are well trained and supported, and you're actively addressing the ways that stigma can deter your efforts, which every clinic will likely experience in some way. And with that, I want to turn it to our third speaker, Paul Berry.
Hello, everybody. I'm really excited to be here with you today. I'm a licensed clinical social worker, and I worked in a clinic in a collaborative care setting as a care manager in a small clinic where we had folks with substance use disorder. So I'm going to recap a little bit some of the themes that Mark and Elizabeth have talked about already today. Just some considerations about what we need to take into account when we're forming teams. And of course, in collaborative care, the principal member of the team and the central member of the team is the patient themselves. So let's think about bringing patients into the clinic. Next slide, please. So, there's really a need for a medical clinic to do some pretty serious outreach in order to bring people in. And there's kind of three areas of outreach. One will be into your community. As Elizabeth mentioned, you really want to find out how you can slot into your community and provide services which perhaps aren't already being offered in your primary care setting. And I put treatment here in inverted commas because it's not just about networking with the traditional SUD treatment system, but all those people in your community who might run into these folks who need to know that you're providing this service. And then also, if your clinic's part of a larger organization, you do really need to let everybody know in the wider organization, all those folks who are in your healthcare system, let them know that you'll be offering this service, even down to the folks at the call center who might receive calls from outside for new patients seeking care. Everybody needs to know that you're enthusiastically providing this service. But the best way to find patients is through word of mouth. And it's going to be talking to your established patients in your clinic and your staff about the service that you're providing. And there's this term called an environment of disclosure. Elizabeth just mentioned that in the screening challenges. You really need to let people know that this is a good thing and a safe thing and a helpful thing for your patients to share with you, and that you have realistic and effective treatments for substance use disorder. The next slide, please. So there's some considerable work that you need to do to start off with, to reorient, perhaps, if you have no experience with substance use disorders, to reorient your organization towards the treatment of substance use disorders. We've noticed that there's unfortunately often within the system disincentives for providers to take on this care, specifically primary care providers. This is about productivity metrics, bonus structure, etc. With so much on their plate these days, primary care providers can be reluctant to take on patients who they might perceive as being a lot of work and difficult to slot into their 15-minute visit. And this has already been mentioned, but the clinic culture, people need to know why you're doing this. Why are we now trying to serve people who have substance use disorder? Surely that's not our job. Well, you have to make it very clear why you're doing it, and to give people plenty of time to talk about their reservations and their concerns. The whole clinic has to be behind this in order to provide a welcoming attitude and a welcoming space for the patients. And then the actual clinic, all of the staff need to be oriented to why and how you'll provide this treatment. Why primary care is a good place to do it and how you do it. And especially with alcohol use disorder and opioid use disorder, there are fantastic medication treatments. And lastly, everybody has to talk about stigma. Stigma seems a nice way of saying hatred sometimes. People really can disdain this population. And you don't know who might have very strong feelings based on personal or family history about folks with substance use disorder. So introducing the harm reduction perspective and clarifying that you won't be, hopefully, doing an abstinence-based program, that's going to be probably new information and something that the whole staff has to understand. And you want the whole staff, if you're not there already, to be offering a trauma-informed care orientation to these folks. Next slide, please. So let's talk about preparing the team themselves. In collaborative care, this is the care manager, the primary care provider, and the site consultant, who may be employed by the organization or may be contracted through an agency or something. But the whole team has to be brought together enthusiastically to support this work. People will worry about how time-consuming it's going to be, these extra people on my caseload, how am I going to find time for this, who's going to cover when I'm out, so all those kind of things. But often we've seen, clinical staff just be left to develop their own procedures and policies and forms. I mean, the administration really has to take care of some of this stuff. There'll be patient packets that need to be developed. There will be protocols for the clinical team. These things need to be created with assistance from administration, even down to simple things like making copies of the patient packet so that the provider has them. And then before you start, you have to think about the kind of education and ongoing training that the staff will need and the kind of support they will need to develop what might be a very new practice for them. But it's important not to overlook that within your clinic itself or within your system, you may have great expertise already. There may already be people who have substance use disorder experience who can share that and bring the rest of the team along. So let's think about the actual skills the team will need. Next slide, please. So of course, the team is going to need specific training and adequate training in the evidence-based treatment. Again, when you think about stigma, people may have already ideas about how to treat these folks, but everybody needs to be brought along to use an evidence-based approach. And also, you may need to network with outside recovery services in terms of some patients will need intensification of treatment. So there's going to be a huge group of people, hopefully, that you can see in primary care, but some people, in the same way as with other behavioral health conditions, some people need to be moved to more specialized treatment. And one thing that some providers will have some apprehension about is, these can be very complicated folks. They're not all complicated folks. Not all people with substance use disorders have been affected by social determinants of health, but certainly the staff are going to be worrying about this. And as Mark mentioned, this is the benefit of a team approach, that some of these other issues are affecting people's ability to recover, such as trauma, being the victims of racism and other oppressions, and homelessness. Those are all things that there needs to be at least some strategy developed to work with. So, and the most important thing we view here at the UW in terms of treatment is that people have a harm reduction approach. So that this is something that really needs to be taught sometimes to a team, just that we want to try and have a patient-centered approach where the patient's a full partner in their treatment. And so the things that we use to help assess recovery and help assess progress, things like urine drug screens, these aren't used as a punitive measure. These are just other ways of getting information that hopefully, in an effective program, confirming information that the patient's already shared with us. But there are complications with people's path to recovery. And when we're treating, say, opioid use disorder, it's very likely there'll be other substance use issues going on in the person's lives. So what's the clinic's approach going to be to that? And what's the clinic's approach going to be to a recurrence of symptoms? We hope that you'd take a chronic disease approach and just treat these things in the same way as you'd treat somebody who had diabetes or high blood pressure. Nobody is successful right away, and people often have multiple conditions. So how is the team going to approach that in this perhaps novel situation of treating somebody with a substance use disorder who has other things going on in their lives related to substances? So let's think about some actual practical issues now about engaging patients. Next slide, please. So you're probably going to have to change some of your approach. And there's a flexibility was mentioned on the previous slide. The kind of providers who do best taking on this new work are ones who can be pretty flexible. So not every clinic has flexibility in appointments or flexibility in provider schedules. But one thing you really want to think about is how can you get someone in quickly? If you have a 2-month wait for your first new patient appointment, that's not going to work with somebody who is wanting to explore, calling in today, who has some motivation today to start on their path to recovery. So we would encourage clinics to offer a low barrier, high access kind of approach. So short wait times to appointments. You also need to face the fact that some of these folks may have difficulty showing up to their appointments in time. So what are you going to do with somebody who shows late or no shows for an appointment, who's critically out of their medication? Is there a possibility in your setting to have some kind of drop-in time, or can providers be allowed to have a set-aside appointment today for people who have an urgent need to come back in because they've missed their appointment? And lastly, these folks, we've all mentioned stigma. These folks have a hard time accessing care because they've had such negative experiences in the past. So they need a lot of support and encouragement to be successful. Places we've worked with that have focused a lot on outreach, they've found that really being persistent and intensive in calling people in has had a great success. So the ability to send out personalized appointment reminders, the care manager perhaps joining the PCP in the visit so they can get their visit in, the care manager checking in with the patient after their PCP visit to see how it went. And I mentioned here varied contact modalities. We should be as accessible as we possibly can be. So that means if you can, having your team able to contact patients, say with text, having a direct number that a patient can call a care manager back. These folks have had a hard time before, as I mentioned. So we really need to work, I think, extra hard on making sure we have a successful relationship with them. So I just want to mention a couple of other team members who you might think about. So I'll just touch on this very briefly. Next slide, please. In the office-based opioid treatment model, the nurse care manager has a very, very significant role. She or he takes on some of the duties of the PCP. So in collaborative care, we encourage clinics to use nurses as care managers. And when you're working with medication treatment for SUDs, this might be a particularly effective use of a nurse care manager in a collaborative care team. And then I also want to mention a couple of other possible team members. Next slide, please. I talked about the importance of outreach. Next slide, please. So you might even have somebody who focuses on that, and that's basically what a care manager does. And care managers are different care navigators are different to care managers, and that they might actually get outside the clinic to find patients and bring patients in, and to network with the other referral settings in your community. And lastly, I would say it's really worth giving some consideration to having a peer member of the team, either a peer counselor or a recovery coach. Since folks with SUDs have such difficulty accessing care, it's certainly helpful for your patients to know there's somebody on the team who has lived experience. And the peer counselor being able to share with the clinical team the perspective of lived experience, that can be a great addition to our clinical expertise. So that's all I had about teams. So I'll pass it back to Monica.
Thanks so much, Paul. So, many thanks to not just Paul, but all of the presenters for the valuable information that you've shared and stepping up to give us some of the learning and lived experiences that you've had. I know we won't have time to launch into a full Q&A. The questions are being answered in the chat box, and we will drop a link for attendees to fill out a survey. But there is one question that I think comes up often that I would like to get some input from you all as panelists about, if that's okay, before closing out for today. And that is around 42 CFR. So there was a comment made about how behavioral health programs within primary care clinics are able to implement substance use care with the 42 CFR laws having more stricter confidentiality rules than HIPAA, and just how individuals have been able to work through that the barriers of that within their EHR and things of that nature. So just wondering if any of you could comment to that or have any thoughts around that.
Sure, I'll jump in. So this is Mark Duncan. This is definitely a common concern. One of the things, if you look at 42 CFR Part 2, is some of the language around that is in regards to if a clinic holds itself out as a kind of dedicated SUD treatment. And if you are doing this in a integrated way in your existing collaborative care where you're also treating mental health disorders, this in my opinion would not apply to you, and that has been the broad interpretation of many of the sites that are working in this research on this research project that Elizabeth and Paul had referenced. That is the case here at the University of Washington. When I have patients that are coming in at my collaborative care that may have alcohol or opioid use, in addition to their depression and anxiety, we're treating the whole person like the rest of the primary care clinic is, and that then puts us in a separate category, and the 42 CFR Part 2 regulations would not pertain to.
Gotcha. Thanks, Mark, for that clarity. I think that that's something that comes up often, so definitely glad to get that clarity. If you would advance to the next slide, please. I just want to kind of give a recap from all of this great information from today. Some of the things that I definitely heard and saw throughout the presentations is that there's robust evidence-based model for integrated care, collaborative care that could be used in treating alcohol and opioid use disorders. And although there are different and are additional things to consider, collaborative care should definitely be utilized to support co-occurring treatment efforts. It's important to really think through substance use screening process, screening tools that you'll use, make sure you have the right resources throughout the whole process. And lastly, successful management of substance use in primary care involves utilizing a patient-centered approach and dismantling stigma. I heard that often throughout all of the presentation. If you'll advance 3 for me, please, 3 slides. So I just want to let everyone know that when you receive the PowerPoint, you'll receive this that also has some additional resources for those of you who are embarking on this journey. We wanted to be able to give you some resources to utilize. It's also in the chat box. Next slide. And come back for our next quarterly webinar series that will be taking place in October. Some of the topics that we have coming up is around collaborative care and advocacy for that in your state. So on the state level, federal level, things of that nature. SBIRT, which were one of the questions that was asked today. So we'll have an opportunity to go in more in depth with that. And then collaborative care and pediatrics. So those are some of the upcoming topics we have going on with our October feature to be around collaborative care and advocacy. So we hope that you register. Please join us. If you have not added yourself onto our listserv to get the updates when new webinar series are coming out or when the next one is and what's the topic and how to register and all of those things, please do join our listserv so you can receive the most up-to-date information from the AIMS Center. And please fill out the survey link for some feedback. Feedback is a gift and we like gifts every day. So give it to us. We appreciate it and you all have an amazing day.